Bueno, muy buenas tardes a todos los amigos gastroenterólogos, endoscopistas, médicos, cirujanos, en especial a todos los miembros de la Sociedad Chilena de Gastroenterología y de la Asociación Chilena de Endoscopía Digestiva. Queremos dar un gran agradecimiento a través del doctor Robinson González a toda la directiva de la CHED que nos ha permitido gentilmente poder realizar esta importante transmisión en vivo. Mi nombre es Andrés Donoso, yo soy cirujano digestivo, soy endoscopista de la Universidad Católica y es mi gran honor poder presentar a un muy querido amigo de hace años ya, que es el doctor Tsukasa Ishida. El doctor Tsukasa Ishida es gastroenterólogo, es experto endoscopista de la Universidad de Kobe en Japón, a quien yo he tenido el agrado de conocer hace 5 años ya, con quien nos une una muy gran amistad y de quien he aprendido mucho. Él por primera vez está en Chile, ha tenido la oportunidad de compartir ya con nosotros, de estar en el operativo Nueva Imperial, y él ha tenido la gran gentileza de poder ofrecer hoy una charla para todos nosotros vía streaming acerca de cómo realizar una endoscopía de screening, especialmente enfocada en el cáncer gástrico. Así que reitero mis más sinceros agradecimientos a toda la directiva de la CHED y sin más presentación quiero dejar con ustedes al doctor Tsukasa Ishida. So Ishida Sensei, please, the microphone is all yours. Okay. Please.
Thank you very much for inviting me. I'm very happy for these invitations. I'm deeply appreciate Dr. Donoso and Achet. So I'm talking about the quality indicator for EZD screening endoscopy. So how to detect the early cancers? So I would like to introduce my facilities, our facilities. This is Kobe University Endoscopy Unit. So as you see, this is new technology endoscopies. They improve the definition and the eye image, such as Blu-ray, Blue Laser image mode, and the NVI image mode. So this is an imaging endoscopy, gives someone help to detect the early cancerous lesions. Narrowband imaging and the blue light imaging produced by Fujifilms. As you know, EZD need to check from oral cavity to duodenum. So the most important things for EZD screening is does not overlook cancers. We think the one of the key point find out the precursor regions of cancer. For example, pharynx, esophageal is low-grade intraepithelium dysplasia. So, and EG junction is Barrett esophagus, and the esophageal esophagitis is high risk of the Barrett adenocarcinoma. So, and stomach is H. pylori associated atrophic gastritis, also high risk regions. So I show the oral cavity precursor regions. As you can see, this is NBI imaging. So little bit magnified images. So you can see that one is low-grade dysplasia regions. So if you can see these regions, you should observe the details. So this region shows a irregular epithelial change compared with the normal area. This is diagnosed the cancerous regions. So don't miss these regions. I would like to explain about the esophagus regions. So esophageal cancer is two types of cancers. So squamous cell carcinoma is originated from entire esophagus. So mainly esophageal region covered by epithelium squamous cells. And adenocarcinoma is originated from Barrett esophagus. I show you the incidence rate and the mortality number of esophageal cancer between Japan and Chile. As you see, the percent of mortality number divided by the incidence number in Chile is lower than Japan. So we have to detect more earlier stage of cancers. This I show the risk factors squamous cell carcinoma. The risk factor are old age and men and alcohol and tobacco and the lack of vitamins. So this is early stage of squamous cell carcinoma lesions. You can see the white light images and then change the NBI image. Little bit brownish, you can see the brownish areas. So if you magnify the endoscopy, you can detect the irregular vessels. So if you see these regions, you should take a biopsy, and then you should resect by endoscopy, hopefully. So I would like to show my experience cases. This is a 63 years old man. He had a history of hypopharynx cancer after radiation therapy. So he have risk of the esophageal cancer also. This slide shows the NBI images with magnification. We suspect early cancerous lesion, but histopathological result is inflammations. So, however, we performed endoscopy after 1 year from previous examination. So the lesion rapidly growing up to the advanced cancers. Sometimes esophageal biopsy is difficult to obtain the adequate sample. So we have to check more earlier again. So this is a very disappointing experience for me. So this is esophageal adenocarcinoma. This I show the risk factor, men and obesity and then GERD and Barrett esophagus. So it's important Barrett esophagus. Japanese guidelines a little bit different definition as Barrett esophagus. In Japan, the area with the parasite, the end of parasite vessels and squamous columnar junction between these area is a Barrett esophagus. But Western countries, the area between the squamous columnar junction and the proximal margin of gastric hold with historical intestinal metaplasia is defined as a Barrett esophagus. So this is we separate between the long segment Barrett and the short segment Barrett. Short segment Barrett defined less shorter than 3 centimeters. So long segment barrette is longer than 3 centimeters. I show you the region of esophageal adenocarcinoma in NBI images. So you can see the irregular surface, a little bit different this area compared with the normal area. So a little bit larger surface. So this is high-grade dysplasia regions. So, and then left side you can see the irregular vessels. This is also cancerous regions. So if you see these regions, you should take a biopsy. So I would like to show the images. This is high-grade dysplasia originate from long segment barrettes. So I can see the magnified images. So this is also surface is irregular. So we are resect by ESD method. But fortunately, this is very superficial region, but horizontal margin is positive. So sometimes difficult to detect the border by even if the magnified with the NBI images. This is also esophageal adenocarcinoma, originated from the long segment barrette esophagus. It can observe the irregular vessel and the surface. So we try to resect by ESD method. So also this region, horizontal margin is positive. And then the depth of the invasion is SM2. But fortunately, this patient is 86 years old. There is no recurrence for 4 years. So now he has 90 years old, but still not recurrent. So we stopped the observed because he's very old. So next slide shows this is benign regions. As you can see, this area. So this is hard to recognize the surface, but you can see this area. So this is not irregular. This area is only inflammation. But sometimes some cases is difficult to diagnose. This is cancerous regions. You can see that this is magnified images. So if they take a biopsy this area, this is cancerous regions. So another case I present show you. This is also adenocarcinomas. So it take you can see the NBI images. So if this area magnified, you can see the irregular vessels. So this is also cancerous regions. So we are resected by whole tumor. So this is curative resections. And also this is cancerous region. This area is covered the squamous epithelium. So this, but you can see this area by NBI images. Little bit irregular. You can see the irregular vessels. And then when I spray the acetic acid, little bit you can observe the opening of the cancerous gland. So this is also squamous adenocarcinomas. Sometimes this is also cancerous region, but this remain it looks like regular regions. But if you cannot cannot understand the regular or regulars, you should take a biopsy. So and you this is detect the borderline, so you can take a biopsy. So result is cancerous regions. We check the location of the cancerous region from short segment Barrett esophagus. So most of them are located from 0 to 3 o'clock. These areas are most common esophageal cancerous regions occurred. So if it is difficult to observe the EG junction caused by severe reflux, so I recommend observe that regions, focus on these regions. I can show you the finally I show you the cancerous regions. This is also early stage of it looks like early stage of cancer, but I try to resect by ESD method, but unfortunately this is the very deep invasion regions. So he is already have lymph node metastasis. So sometimes and then historical report is poorly differentiated. Sometimes be careful these regions. If the even if this region is a very shallow, suspect the shallow regions, but the final result is a very deep invaded regions. So I show the characteristic of the EAC from Barrett esophagus. We recommend a target biopsy for Japanese way. The Western country recommend random biopsy, but we recommend target biopsy for diagnosis of esophageal adenocarcinoma. But the problem of the diagnosis, the detection is borderline between the cancer and the normal, sometimes difficult. And then prediction of the depth of invasion also sometimes difficult. So still remain the problems for adenocarcinomas. So I'm talking about the stomach regions. First of all, I show the stomach cancer incident map in the world. You can see that Chile is also high incident area. The Japanese also, in Japan also high incident area. So similar incident rate of the stomach cancers. But as you can see, the comparison of stomach cancer incident and the mortality rate, Japan is a high incidence stomach cancer, but the mortality rate is low compared with Chile's. So now we are talking about how to detect the high-risk group and observe the systemic procedures and recognize early cancer regions. This is a famous paper for the incident rate of gastric cancer compared between the H. pylori negative and the positives. So if the H. pylori negative is very low incident rate of gastric cancer. But if the positive, H. pylori positive incident rate is higher compared with the negative groups. And also, it's important of grade of atrophy. If the have a severe atrophy, incident rate is also high. And then pangastritis and the corpus predominant region is also high incident of gastric cancer. So, and then intestinal, if the present intestinal metaplasia, also high risk of the cancers. So now we are thinking about the H. pylori infection and the gastritis, atrophy, intestinal metaplasia. Finally, this occurred the dysplasia and the cancers. So how evaluated? We are focused on the atrophic gastritis. So how we evaluated the atrophic gastritis? In Japan, we usually use a Kimura Takemoto classification. It is very simple, but its classification has some problems because it is subjective classifications. It is not matched by endoscopists, and it is sometimes difficult to determine the borderline of the borderlines, and then sometimes if the H. pylori eradicated, difficult to determine the borderline also. But it has evidence. So if the atrophic gastritis is spreading, cancerous lesion incident rate is increasing. So this is normal stomachs is low risk. This is atrophic gastritis. Is a high risk of gastric cancers. So when I watched the Chilean stomach for 4 days in Nuara Imperial, sometimes it is hard to determine whether H. pylori infected or not. We are hard to determine the border of the atrophic area by endoscopy. So in Western country, the Olga staging system is and the seasoning system is widely spreading to evaluate atrophic area. So a little bit different between the Japanese stomach and the Chilean stomachs. So I agreed to take a biopsy, evaluate atrophic area. So mainly if the spreading atrophic areas, cancer risk is higher than normal stomachs. So I can show you the way to screening procedure in Japan. So this is my way. I initially using check pharynx, larynx inside the entrance of esophagus by image and enhanced endoscopy. So this area are covered by squamous cells. You can check the squamous carcinoma using IEE. Okay. And then inside the esophagus, I usually check by white images while insertion and check by IE while withdrawal procedures. So, but of course, you can check the IE white while insertion. I usually check surface and white surface is white or not, or rough, or so. If the white covered whitish area and rough, so you can gently check the esophagus. And then you can check the ECG. Also, we check the white light images and the image and enhanced endoscopy images. If it has a reddish area in this area, we focus on the IE. So this is screening method my way. Initially suction the air and the water gently, and then going to the duodenum. On the way to duodenum, I observed lower corpus and the great curvature and surrounding pillows rings. You can see this a lot of you can see a lot of reddish spots. These stomach is be careful to cancerous regions. So it has atrophic gastritis. Okay, and I checked the bulbs. The mainly anterior walls checked the first, because almost the duodenal is also occurred in this area. So, and then you can see that this is Brunel gland, and also this is ampullus. Okay, so this is and when I back to antrum, we supply the air sufficiently, and we check the details. And this area is a high incident of gastric cancer because atrophic gastritis start from these areas. So differentiated adenocarcinoma is mainly occur the lower part of stomach. So we are checking details, and then supply the suffuration, and then remove the bubbles. So washing by water with dimeticons. And then I observe the fornix area, and then after suction the waters. So you can see that this is a lot of red spots. So this is it has a gastritis, and the cardia area is easy to miss the cancerous region. So we are quite gently observed these areas. And then we check the lesser curvature of the corpus areas. Sometimes using NBI images. So slowly we are slowly checking up these regions. Finally, I will check the corpus, mainly greater curvatures. You can see the patient has atrophic gastritis. So if there is attached mucus, remove the washing by waters. So we observe the anterior and the posterior, and then mainly we can observe the greater curvatures. So if the attached mucus cannot observe these regions, so we spraying spray the water and then surface, clean the surface, and then we are checking. As you can see, this is not have irregular vessels and surface and demarcation lines. So this is only gastritis. So can you predict whether H. pylori infected or not by endoscopies? Which is Helicobacter infected stomach? This is atrophic gastritis. This is normal stomach. So sometimes detect the borderline, the atrophic areas, lesser curvature of middle corpus, and then you can see detect the xanthomas. This is you can see detect the red streak and the regular arrangement correcting venous. This is atrophic gastritis, so you cannot see the fold. So this is open type atrophic gastritis. This is normal mucus, then remain the fold, and then it will be whiter than the gastritis. If the have a gastritis, it will be reddish. So it has a erythemas. So this is metaplastic regions. So the metaplastic region has a whitish regions. This is the metaplastic findings by NBI views. Right side is normal mucosa, and then left side is metaplastic change of mucosa. Light blue crest, you can see the along the these areas looks like bruise. So this is, it has a chronic gastritis and intestinal metaplasias. So this is regular arrangement correcting menus. This is also it sometimes atrophic if the atrophic gastritis has some areas disappeared regular arrangement of correcting venous. So you can check the whole surface. So if you see the there is not disappear point, this is normal stomachs. This is also stomach normals. If you see the spotty redness is also have gastritis. So what do you think this? Also this is also H. pylori positive regions. The mucosa is a little bit swelling. This is normal. So in Japan, it's very easy to detect the H. pylori negative or not. So this is also so you if you can see the hyperplastic polyps, also this is suspect the H. pylori infections. This is a normal benign lesions. You can see the NBI images. Surface is tortuous, but it is irregular. If the H. pylori eradicated, these polyp is 80% is shrink or disappeared. So it is important. Hyperplastic is caused by inflammations. This is a fundic gland polyps. you can see the NBI images. This is round pit pattern, and then expanding blood vessels. So this is a typically fundic gland polyps. This is nodular gastritis with undifferentiated cancerous lesions. So if you see the nodular gastritis, this is very high risk of the cancerous lesions. So finally, how to recognize, talking about how to recognize early cancerous lesions. We should not overlook early gastric cancers. Where is cancerous lesions? So this is depressed areas. It's important remove the surface mucus. If the have bubbles, cannot observe the cancerous lesions. Also, we do not expand the gastric wall. We may fail to detect the cancerous lesions. This is there is a cancerous lesion, but if the suffered areas sufficiently not detect. So Paris classification proposes morphology of early gastric cancer. Almost early gastric cancer is depressed type, so you should check depressed areas mainly. So this is high-grade dysplasias. And I show that early gastric cancer, can you detect the lesions? If the spray and dye is more easy to detect. So this is elevated lesion. This is depressed lesions. So indigo carmine assists the depressed and elevated lesion is more enhanced. Also, it's important color. If the color is reddish, it suspect the tumor lesions, and the whitish area also, and this is suspect of the undifferentiated carcinomas. So I show you the subtle undifferentiated lesions. You can see the whitish areas. This is a very small early cancerous lesions. So you can see the more details. So little bit whitish compared with outside the areas. So you can change. You can see the NBI images. So this is demarcation lines, and then irregular vessel patterns and the surface patterns. Finally, we resect by ESDs. This is different signet ring cell carcinoma, but mucosal region, and then only 4 millimeters. So if you see the spontaneous bleeding areas, you can also focus on these areas. And then this is cancerous region in cardia. This region was overlooked 1 year before. We should not overlook these regions for screening. So you can see the NBI images. This is demarcation line and irregular vessels. So we are resect by endoscopy, but unfortunately this is not complete resections. So image enhanced endoscopy is more convenient to detect the cancerous regions. we usually use BLI and NBI images. Sometimes chromo endoscopy also useful for detection of the early cancerous lesions. Yao proposed a method of diagnosis diagnose the cancerous lesions. He identified evaluate 3 patterns of gastric mucosa: demarcation line and irregular microvessel patterns and irregular microsurface patterns. If these lesions have gastric cancers, so you can see that this is regular pattern, regular vessels, regular surface. This is irregular vascular patterns, irregular surface. This is absent. So I can show you some cases. Case 1 is a white light images with indigo calamine spraying dye, so it can observe the depressed regions. So we look the NBI image with magnifications. So you can see the demarcation lines and with irregular vessel patterns. But yes, so it is cancerous regions. So this is little bit irregular, and look like a corkscrews. So we suspect the undifferentiated type gastric cancerous regions. But this is we predict the mucosa region and less than 2 centimeters. So we perform the endoscopic resections. Fortunately, this is poor, even if the poorly undifferentiated carcinoma, but just 12 millimeter and mucosal regions, no vascular invasions. So it can observe. And I'd like to show the case 2. So this is also depressed lesions, but hold is a little bit remained supply the air sufficiently, even if the supply the air sufficiently is remain this hold. So this region is suspect the submucosal regions, invade the submucosal regions. So you can see detect the border lines, demarcation lines, and then irregular vessels and the irregular surface. So we finally diagnosed gastric cancer, but it suspect the submucosal invaded cancers. But Japanese guideline, if the well differentiated adenocarcinoma, it can resect by endoscopy. So even if this final result is SM1, is a depth of invasion is 300 micrograms. So this is curative resection. It can be observed. So case 3. He has a history of H. pylori eradications. So this is very difficult to determine the borders. Sometimes if after H. pylori eradications, so sometimes difficult to recognize the borders. But there is the borders, and then irregular surface and then irregular vessels. So and then we dissect by endoscopy. So but we a little bit dissect by large margins. So sometimes difficult to border, but if you detect hard to recognize the border, you should take resect by large specimens. This is special case. you can see the uh, fundic gland polyps, and with little bit, this is like submucosal lesions. So we focus on these areas. It remained surface is remained epithelium is as normal, but there is elongated vessels. So this is, and part of the surface is you can see the irregular vessels. So it takes a biopsy, but it suspect the cancerous regions. So we can try to resect by endoscope. So final report is adenocarcinoma, fundic gland types. So this is a special type of gastric cancers. So I can show you the characteristic gastric cancer fundic gland types. They arise most commonly from normal gastric mucosa. So fundic gland regions without intestinal metaplasia. So 85% is H. pylori negatives. So they are recognized as smooth, elevated, or depressed regions. So and then they tend to invade the submucosal layer, while they rarely show the lymphomatic and the venous invasions. They show the histologically mild atypias, and then look like low-grade malignancy. It is thought to be low-grade malignancy. So these regions had to transfer the lymph node metastasis. So we can observe it. So this is conclusion. This is final slides. To detect the early stage of cancers, evaluate of precancerous regions is important. For example, atrophic gastritis is a precancerous region of the stomach cancer, and it is important to search carefully in high-risk patients to detect the early stage of cancerous regions. So if early stage of GI region can be detected, the patient is not only get high curability rate, but also preserve the GI function with good quality of life and prognosis. Thank you very much for the attentions. Thank you. This is my mentor, Dr. Toyonaga, and this is me, and we are my colleagues, and you also, Andres. Thank you very much.
Sí. Okay. Thank you very much, Dr. Ishida, for your amazing presentation and for your kindness to offer this lecture for us and for all the Chilean doctors. So, just for you to know, now we have 19 doctors, Chilean doctors, among Santiago and some other cities connect to this live transmission. For you to know, you have 90 doctors.
Wow, amazing!
Who are very curious about how you perform the diagnostic endoscopy. And actually, we have some questions.
Okay.
So, if you allow me, I will ask for my colleagues. And we will begin with the esophagus, okay?
Okay.
So, my main, actually we talked about this before. I would like to know about Barrett esophagus, especially about long Barrett esophagus.
Yes.
So you show us a very nice, interesting cases about endoscopic submucosal dissection of lesions in a Barrett esophagus with positive lateral margins. Yeah. So my question is about the Western way about EMR, staging EMR. I mean, if you have a long Barrett with a small nodule, so to speak, what's 1 centimeter. What about to perform EMR and to look if the patient has, for instance, intramucosal cancer? It is curative, and then you perform a radiofrequency ablation for the rest of the Barrett. Or if the patient has a submucosal invasion in that mucosectomy EMR specimen, you submit to surgery. So, because as you know, I love ESD, but many Western doctors will ask about the necessity of such a expensive and difficult procedure if we are letting in the esophagus the main disease that is the Barrett esophagus. So, how do you approach this question? Please, can you tell about it?
Yes. Yes, I know that the ESD is difficult about the long segment Barrett esophagus. But yes, I show the how the border is a detection even if the using magnified NVR images. But yes, I think I agree to the I agree to EMR with radio frequency ablations, but I suspect the radio frequency ablation is really completely cauterize the mucosal regions. Sometimes I heard if the cauterized Barrett esophagus, sometimes recurrent look like submucosal lesions occurred after cauterized lesions. So ESD is more resect by deep layers. So I don't know the prognosis of the radiofrequency ablations, but some cases it's a very good, but if the there is muscular mucosa invaded regions, it's not curative by radiofrequency regions. So I but still ESD is difficult. So but Japanese way is always resect by endoscopy, so ESD method. So even if the horizontal margins positive, we can try the ESD again. So we have skills, but these regions have a very fibrotic region, so it resects. This resection is very hard to resect. So technically is difficult. I know the technically difficult.
Yeah. So in this very same case, if you have a successful ESD, I mean curative resection of a mucosal cancer on a Barrett esophagus, on a long Barrett esophagus, but curative resection, completely curative resection. What do you usually do in Japan for the rest of the Barrett segment? You just follow up, or you treat it in some way?
Yes.
What do you do?
Follow up them every 6 to 1 year. But I experienced 2 cases after ESDs, recurrent other areas occurred cancerous lesions in other Barrett esophagus. So if you prevent these lesions, very useful for the radio frequency ablation is very useful for prevention for cancerous new cancerous regions.
Thank you very much, Dr. Ishida. And please, Dr. Araya, he's the chief of Clínica Los Andes of endoscopy. He would like to know about a Japanese way to look for the Barrett esophagus in terms of how you communicate among you. Do you usually use the Praga classification
Yes.
or not?
Yes, we use the classification, but not widely spread. Some doctors use these classifications.
Someone, but not all.
Not all.
Not all. Okay, okay. And I'm sorry, someone is calling me, so I cannot see the question. Okay, we already see that. Okay. Also, Dr. Araya would like to ask you if you can perform a brief comments about the routine observation of the GI junction under the retroflex view. Do you think it is good to not only observe the escamocolumnar junction under forward view, but also under retroflex view? Do you can see something else? It is good to try to do it always. What do you think?
Yes. If how to recognize the forward views, I recommend look by retroflex views. So I agree. Yeah.
Okay. And Dr. Araya also would like to know because about the white light image of chronic atrophic gastritis. There are many debate usually here in Western world, and I think in Chile it's a very popular subject for discussion, because I think most of the doctors actually do not believe on the white light image endoscopic diagnosis of atrophic gastritis. Some very important doctor usually says that about the folds, that you cannot rely on the disappearance of the gastric folds, but because if you insufflate enough, every patient will disappear the folds, and then if you deflate the stomach, then you have the folds again. So, but I have been in there and I have seen as a reliable sign. Of course, you have to be carefully, but can you explain what is your most reliable sign of chronic atrophy, gastric atrophy under white light image? Is the folds, the vascular transparency, or the whitish mucosa? Can you go a little bit deeper on that subject, please?
I think diffuse erythema is it's important since I think H. pylori is cause erythemas inflammation. So little bit have erythema compared with normal stomachs. So erythema and so I observed LCI. LCI is easy to detect the borderline, the atrophic area, and so some assist.
So if you allow me, because I think this is a very, very important subject, I will take the word in Spanish just 30 seconds, because of the public, all the Chilean doctors could understand quite well. Okay. Si me permiten, vamos a hablar un segundo en español respecto a este tema del diagnóstico bajo luz blanca de la gastritis crónica atrófica. Una de las cosas que yo trataba de conversar con el doctor Ishida es que, por lo que yo he visto en Japón, siempre la línea demarcatoria es extremadamente visible, muy fácilmente determinable en Japón, y a veces no se da el caso acá en Chile, donde podemos tener en el fondo un compromiso más difuso. De ahí que el tema de la clasificación por Kimura Takemoto sea un poco más compleja o más polémica acá en Chile. Sin embargo, una de las cosas que nosotros tuvimos la oportunidad de estar 4 días en Nueva Imperial, y la verdad es que si uno se lava bien el estómago, y busca en el fondo, sabiendo lo que esta línea, cómo realmente se ve la línea demarcatoria, yo creo que no hay mayor diferencia y que se puede determinar. Quizás lo que sería muy interesante poder comparar es que una vez que uno diagnostica una línea demarcatoria, poder tomar biopsias a ambos lados y poder saber si nuestro diagnóstico de gastritis crónica trófica por bajo luz blanca, eso no es confiable. Yo creo que eso sería muy interesante. Y respecto a este punto, con el doctor Chida encontramos que el LSI era realmente una muy buena tecnología comparada con otras para poder determinar esta línea demarcatoria, así que a quienes tengan disponible esto yo los animo a que traten de hacerlo, sobre todo los que van a ir a Nueva Imperial en este mes que viene. I'm sorry, Dr. Ishida, because that was a very
Yeah.
important point, I think. So, can you comment us because it's very popular now among Chilean endoscopists to use the Yagi classification. Actually, you arrived here in Chile and you said to me, I don't use Yagi classification. What is that?
Yes.
But every Chilean doctor is now trying to apply the Yagi classification, and we have this nice chance for these 4 days to apply Yagi classification.
Yeah.
So, can you comment? Please feel free, whether you like it or not, whether can be useful or not. Please, what are your feelings about Yagi classification?
Okay. Yagi classification is it's important. The if the sometimes Yagi classification is different. The part of depend on the parts. So if the atrophic areas, Yagi classification is elevate the B1, B2 proceeding classification. But if the does not have atrophic areas, so sometimes B zeros. So Yagi classification is important, but it's better to choose areas. So decide the areas. So regarding depend on the areas, Yagi classification is quite different. So this is very important point, I think.
Yeah, I think so. Nosotros nos pudimos dar cuenta en el operativo en estos cortos 4 días que realmente, bueno, y todos saben que varía mucho. Lamentablemente uno tiene que tratar de estandarizar, sobre todo cuando se quiere obtener datos masivos o hacer estudios. Y nosotros, me parece, corríjame por el chat si estoy equivocado, hemos elegido estandarizar la curvatura menor a nivel de cuerpo medio, o sea, la zona supraangular, pero realmente puede ser muy distinto donde uno vea el Yagi. De manera que maybe the better would be to see the overall stomach under white light image, try to look for specific areas and
Yes.
targetly apply the Yagi classification.
Yes.
And maybe we should choose the worst because we are trying to stratify risk, and then to go directly to that point to take our biopsies.
Yes.
Excuse me, y si me permiten, otro punto importante que yo creo que ha sido muy interesante, al menos para mí aprender, es el tema de dejar fotografiado el lugar donde uno, en una visión panorámica, donde uno toma la biopsia. Yo creo que eso es bastante importante y se lo había escuchado, de hecho, ya a otros doctores cuando les he preguntado en Japón, y también al doctor Odagaki, que estaba viviendo acá en Chile, como ustedes saben. I was telling them that you usually take the picture of where you take the biopsy always.
Yeah.
I think that it is important then to look at this.
Yes.
Can you a brief comment about that, please?
Yes. Yeah. I usually take pictures when take a biopsies because yeah, atrophic. If this area have atrophic areas, so you can check the endoscopic image and the pathological report. So it has a result final. It has so the check the between the atrophic area. If the image check with it's important. Both it's important taking the part of the biopsy area is. I'm sorry.
You mean maybe, correct me if I'm wrong, but what do you want to say if that we have to record by a whole picture where we take the biopsy and then compare to the pathology report?
Yes.
So then if we have any important diagnosis in the pathology report, we can go again and check that specific area.
Yes.
That is the point?
Yes.
Yeah, I think it's very important. So Dr. Ichida, Dr. Pablo Cortés of Clínica Alemana would like to know if you perform a screening endoscopy and you do not find any early gastric cancer. When would you usually recommend the next endoscopy? There is a difference in the in the surveillance time if you have a normal endoscopy, or do you see any signs of atrophy?
If I presentation cases a lot of there is a lot of erythemas, and then there is atrophic gastritis. So these patients I recommend every 1 year performing endoscopies. So in Japan is the endoscopy fees it's not expensive, so I recommend every year.
So let's put to the different side of the border. I mean, if you have a patient, let's say 50 years old, and you said by endoscopy means that it has a normal gastric mucosa without H. pylori infection, what do you recommend? He needs to come again someday for endoscopy? Never? What in what time? Normal gastric examination.
I recommend that every 3 years.
Every 3 years
Yes.
for a normal stomach.
Yes.
Okay, and
Because
let's say your diagnosis is atrophy. Let's say an open Kimura Takimoto. What we should think like Olga 4. Your recommendation is in
every 1 year.
every 1 year.
Yes.
So for high risk patient, every 1 year, and for non-risk patient, let's say every 3 years.
Yes, because we can check the esophagus and the stomach, also duodenum. So
So this is a very important issue. Yo creo que este es un punto muy importante que tenemos que tratar de no tenemos que enfocarnos sí o sí en el cáncer gástrico, pero tenemos que tratar de no dejar fuera en el fondo el resto del examen. Let's say that this is not only the stomach, but I mean in Japan this is very important also the screening for the esophagus and the duodenum.
Yes.
Maybe we don't have so accurately data to know how much time we have to do it, but at least in Japan you know that the esophagus is very important. It's quite important as well for screening. And Dr. Araya would like to know if you only rely, or most of the Japanese endoscopists rely on the atrophy to stratify the risk, or do you also are looking or aware of the intestinal metaplasia?
Yes, but intestinal metaplasia is a little bit hard to detect by endoscopy. So we are not usually take a biopsy for the atrophic and metaplastic area. So I know the intestinal metaplasia is important for cancer lesions, but in Japan it's not usually check the intestinal metaplasia.
You are not usually checking for intestinal metaplasia.
Yes.
You are aware of the most of the atrophy.
Yes.
Okay. But maybe I'm wrong. But some papers are comparing the Olga with Olgim, and maybe it's more accurately Olgim about in that specific papers. Intestinal metaplasia. I think that is the reason because Dr. Araya is asking this. Because but in Japan you mainly focus on atrophy. Atrophy. Okay, thank you very much. And also Dr. Araya would like to know if all your lesions would going to for endoscopic submucosal dissection, or do you see in Japan or as a Japanese doctor some place for the EMR?
Now in Japan, is EMR stomach region is not popular EMR method. We are we want to complete resection. So if the small regions we we resect the whole surrounding mucus. So after the snaring, so this is a hybrid method of ESD.
Hybrid ESD, the so-called hybrid ESD.
Yes.
Yeah.
It's
Just,
more convenient.
I'm sorry, just 30 seconds. Este es un punto importante porque hablábamos también con esto de este tema con el doctor Ishida no imperial. A veces cuando tienen lesiones muy pequeñas realmente es difícil tratar de hacer una ESD, pero a ellos les importa mucho en el fondo que la calidad de la pieza de resección sea muy buena y que tengan una adecuada profundidad y todo el tejido submucoso. Entonces, en general lo que ellos hacen es que realizan una elevación de la lesión, un corte circunferencial como para crear un pseudopólipo, pero acá el detalle técnico muy importante es la desconexión de la lesión, o sea, no solamente cortar la mucosa, sino que ir elevando y cortar toda la submucosa hasta la muscular y luego con un asa tomar la lesión para poder resecarla como una, digamos, polipectomía. Esta es la ISD híbrida, en el fondo, o como de hecho empezó la ISD en el 96 con el IT Knife, o sea, primero cortar todo alrededor y después con un asa, porque cuando uno quiere sacar una pieza que va a tener 1,5 centímetros por ISD puede ser muy difícil, pero a veces por mucosectomía la calidad de la pieza y el grueso de la pieza puede no ser el adecuado. I was talking about that sometimes for a tiny specimen ESD could be really hard.
Yeah.
So, but even a tiny lesion, you want a good quality specimen. So you recommend to cut first the circumference and then perform the hybrid ESD with a snare.
Yes.
But I think that a very important point, if you allow me to say this, is that the trimming, because sometimes a doctor could say, okay, EMR is easy, let's do EMR. But if you do not perform the trimming, even if you cut the mucosa, your specimen is not good quality, even if you snare it.
Yes.
Can you just a brief explanation about trimming, please, about this point?
Yes. Yeah, it's important of trimming because if the mucosal cutting is superficial, hard to grasp the snares. So this is my facility ways, but I think less than 1 centimeter region is also EMR is also good quality of resection. So some facilities still performing a EMR, so less than 10 centimeter regions. So it is we have an expert of the ESD, so we are usually use ESD method. So it's a depend on the facilities
And the doctors.
Yeah, doctors.
And nobody has asked this, but I think it is very interesting point that I'm sorry, they are sending another question. Let me see. But about the biopsies, usually all doctors are very curious about how many biopsies, where to take biopsies, and whether or not it is convenient to take biopsy. So nobody is asking this, but I will tell you this question because I think is more than one doctor will be surprised about when you show this beautiful 2B esophageal SCC and you said we should take biopsy. Because usually there is this feeling that if we take biopsies, the endoscopic resection could be compromised. So can you comment about whether we can or we cannot, or if you recommend do not take biopsies on the tiny lesions in the esophagus, the stomach, and very briefly in the colon? How it compromise your endoscopic resection, please?
Okay. I think the in stomach case is not bothered. You don't care to take a biopsy because some if the take a biopsy, not so serious fibrosis occurred, serious fibrosis, but mainly duodenal regions and chronic depressed region is careful to take a biopsy because if these region take a biopsy, occurred severe fibrosis. So when I resect by endoscopy, so difficult to very hard to resect by endoscopic resection. So this region is very careful, but the other regions not so much care because if they take a biopsy, still can resect by ESD method.
Okay, so no problems in the esophagus, no problem at all in the stomach. Usually
Yes.
no problem in the colon, but
Elevated
but
region.
take care with LST non-granular express, especially the depressed type
Yes,
lesion and the
yes,
duodenum.
yes.
O sea, así que como una muy breve regla o receta de cocina, no hay ningún problema en tomar biopsias del esófago, del estómago, ni del colon en las lesiones granulares o grandes, pero hay que no en el duodeno y no en las lesiones planas deprimidas del colon, en los LST no granulares del tipo pseudo deprimido. But here you put an amazing point in the table. So because for me until 2014 didn't even know that you can perform ESD in the duodenum. So maybe there is many doctors that do never have seen that kind of procedures. Ellos hacen ESD en duodeno y eso significa que ellos encuentran lesiones incipientes en el duodeno que son muy similares a los LCT no granulares del colon. Eso es realmente impresionante porque yo me pregunto de dónde salen esas lesiones, porque en general no son de difícil diagnóstico. No sé si ellos tienen más y nosotros menos, si no existen acá, porque incluso si la hipótesis fuera que nosotros no vemos esas lesiones en el duodeno, entonces deberíamos tener más cánceres avanzados de la tercera porción del duodeno, y yo como cirujano les puedo decir que no las vemos. I was highlighting that point of our discussion in No Imperial about the lesions in the duodenum. I'm not quite sure what is happening because we seldom see that kind of LST non-granular type in the duodenum. You can say, okay, it's because you don't diagnose, but if that was the case, we should see many advanced case in the third portion of the duodenum. We didn't see it. So, do you know if there is a special prevalence in Japan compared to other countries of Asia or Western countries? Do you have any data? Because believe me, it's very surprisingly that you have so many duodenum cases. Do you have any data?
I don't have data, but now we are the gather the data, a lot of expert facilities. So, but it is important point. Duodenal advanced cancer is still rare, but now the early region is increasing. So I don't know in the future advanced region is increasing. So, but now early region is increasing, but still advanced region is very rare. So then duodenal ESD is not established safety method. So our facility is not recommend the ESD method, only ESD method. We are usually resect by endoscopy. After resections, we ask the surgeon to suture by laparoscopy. So
Laparoscopic assisted ESD.
yes.
You perform the ESD and then the surgeon under laparoscopy suture the
Yes.
site of the resection, the scar.
Mm.
Okay, Dr. Ishida, just for you to know, more than 90 people connect now on your lecture from Santiago, of course, from La Serena, Concepción, or very far like Punta Arenas, but even not only Chile, but also Bolivia, Buenos Aires in Argentina, and Mendoza. So, what an amazing occasion, what an amazing lecture. Thank you very much for your time, for your outstanding presentation. We have learned a lot, a lot.
Thank you very much.
I mean it, and as a friend, thank you very much. Thank you very much, Dr. Ishida. So,
And
you can say goodbye to all people, please.
thank you very much for invitation of the presentations. I'm deeply appreciate the. I'm first visiting Latin America and also Chile, Chile. So I'm very enjoy I stay in the Chile. So I'm happy to stay in Chile. Thank you very much.
Thank you very much, Dr. Ishida. And now we will enjoy some beers and some churrascos. Okay, thank you very much. Muchas gracias a todos por la asistencia y muchas gracias de nuevo a la CHED, a la directiva y a todos los que se han conectado. De verdad, muchísimas gracias por su atención y por las preguntas. Así que nos estaremos viendo y hasta la próxima. Thank you very much.